Hello, everybody, and thank you so much for joining us tonight for the ASPN Fellows webinar, Surgical Technique and Wound Healing. I'm going to go ahead and pass it over to Dr. Timothy Lubenow.
Good evening, everyone, and welcome to another of our Fellows webinars sponsored by ASPN Society. This particular webinar is entitled Surgical Technique and Wound Healing. I serve as Senior Chair for the Fellows, Residents, and Young Innovators Committee. And in that regard, this Fellows webinar is intended to be fellows training other fellows and young physicians in the early part of their career, certain aspects that are essential to the practice of interventional pain medicine. Joining me tonight is my colleague and friend, Dr. Whitney James. Dr. James, please introduce yourself and our panelists for tonight.
Thank you so much, Dr. Lubenow. Good evening, everyone, and thank you for joining us on this very fundamental topic of surgical technique and wound healing. I hope this is a presentation that you can always return to across the course of your career and provides valuable information for you this evening. It's my pleasure to be here this evening. I am a neurosurgery trained neuromodulatory surgeon and minimally invasive spine surgeon in private practice in Prescott, Arizona. And I am pleased to be able to present a stellar group of fellows to you this evening. We first start off with Dr. Shashank Vodapalli, a PRMNR trained interventional pain fellow at Northwell Health in New York City. Next, we move on to Dr. Vinny Francio, also PMNR trained interventional pain fellow at the University of Kansas, Kansas City. And finally, Dr. Thomas Regan, anesthesiology trained interventional pain fellow at Rush in Chicago, will wrap up the evening for us. So welcome all. And now I'll pass it off to Dr. Shashank Vodapalli, and he'll start us off with the mechanisms of wound healing.
Thank you, Dr. James, for that introduction. Thank you, Dr. Lubenow, and then thank you, ASPN, also for the opportunity to present here tonight. We're going to start here with just an overview of the phases of wound healing. There are 4 phases involved during the wound healing process that we're going to go over today in detail. The first is hemostasis, which isn't depicted here on the graph, but occurs in the seconds to minutes phase right after the incisional incision or the wound occurs, followed by inflammation, followed by proliferation, and finally the maturation and the remodeling stage. The hemostasis isn't seen in this chart, as I said, and the other thing I want to keep in mind is that the wound healing process goes from that seconds to minutes onset all the way up to almost a year, as you can see, all the way up to 300 days or a full year. The 4 phases of wound healing, they have a fair amount of overlap and they aren't distinct from one another, as this diagram shows. So the first phase of wound healing is hemostasis. This is when vasoactive biogenic amines, such as serotonin, as well as catecholamines, such as epinephrine, are released into the area, which stimulates local vasoconstriction. The platelets then fill the injured area by binding exposed von Willebrand's factor, and this subsequently releases ADP, thromboxane A2, and then further serotonin. This attracts more circulating platelets to the area, which quickly forms a platelet plug when they interact with glycoprotein 2B and 3A, as depicted here. These now quote-unquote activated platelets, they signal these extrinsic and intrinsic coagulation cascade that we remember all too well from medical school. Further, kind of just touching on the extrinsic and intrinsic cascades. So the intrinsic cascade starts after the initial injury and the endothelial collagen is exposed. So factors 12, 11, 9, 8 all are part of that pathway, and they meet at factor 10. The extrinsic cascade begins after the endothelial cells themselves release tissue factor, which activates factor 7, which then again meets the intrinsic pathway at factor 10, which is where the common pathway begins. Factor 10 then converts prothrombin to thrombin, which then goes on to convert fibrinogen in the platelet plug to fibrin. Factor 13 at that point as fibrin stabilizing factor that cross-links activated fibrin together. This creates a fibrin mesh, which helps to form a mature clot. The deposited fibrin mesh also acts as a scaffold for various cell types to function in the later phases of the wound healing process, such as leukocytes, fibroblasts, and keratinocytes as well. So moving on to the second phase, which is inflammation. So following the initial 5 to 10 period of vasoconstriction, the surrounding vessels begin to dilate and release pro-inflammatory chemokines and cytokines by the aggregated platelets, which attract neutrophils, macrophages, and lymphocytes to the wound. In the first 24 hours, neutrophils have been shown to be the predominant cell type, and they release prostaglandins such as interleukin-1, TNF-alpha, and TGF-beta to further draw more neutrophils to the wound site. Slowly, after about 2 to 5 days, these neutrophils end up going through apoptosis, which then attracts monocytes to the area, which differentiate into macrophages to help clear the debris of bacteria. So macrophages, once they are drawn to the area, they are present throughout the inflammatory phase, and they're critical in the healing process. Activated macrophages stimulate angiogenesis and fibroplasia, so inhibition of this process can lead to poor wound healing. This is why NSAIDs, corticosteroids, chemotherapy agents, and immunosuppressants can prolong the wound healing process. They also release reactive oxygen species and proteases to kill bacteria and also enhance the inflammatory response by releasing more pro-inflammatory cytokines. The activated macrophages stimulate angiogenesis and fibroplasia by synthesizing vascular endothelial growth factor, fibroblast growth factor, TNF-alpha, TGF-beta, and epidermal growth factor as well. A prolonged inflammatory phase due to increased bacterial load, repeat trauma, persistent foreign material in the wound can lead to chronic wounds, impaired healing, and poor scar formation. This phase is very critical for cellular debridement of the wound, and once it's complete, the proliferative phase can begin. So this is the third phase of wound healing. This begins with reepithelialization. So the stem cells that sit between the dermal and epidermal layer, they differentiate to form keratinocytes and migrate over the wound and fill in the defects. This phase also includes capillary budding, as seen here at the first number 1, and the endothelial cells situated near the intact arterioles and venules are drawn to the area by vascular endothelial growth factor to start creating these new capillaries. Next, there's creation of extracellular matrix to fill in the defects of the wound after the macrophages clear out the debris, which is seen in the number 3 here on the diagram. This protective barrier helps prevent further fluid loss and also prevents further bacterial invasion. Fibroblasts, which are the white cells you see here, situated around the wound, then begin the process of granulation. They're drawn into the area, and once activated, they begin to proliferate to produce collagen, specifically type 3 collagen in this phase. Some then transform into myofibroblasts and begin to actually approximate the wound together. So now we move on to phase 4, which is the remodeling and maturation phase. This phase is important for organized deposition of collagen. Patients with underproduction or overproduction of collagen may have compromised wound strength if it's underproduced, or keloid formation if it's overproduced. Recall that the initial matrix framework that was built through hemostasis with that mature fibrin mesh and clot formation, this is now replaced by glycosaminoglycans, proteoglycans, and other proteins that are synthesized by the fibroblasts in the area. The unorganized framework is then replaced by a more organized framework of collagen. Initially, in the immature scar, there's a higher percentage of type 3 collagen than compared to uninjured skin. There was about 30% type 3 collagen at that point compared to only 10 to 20% of type 3 collagen in uninjured skin. As the wound matures, the percentage of type 3 collagen actually drops to about 10%, and it's replaced by type 1 collagen. This helps with improving this overall wound's tensile strength. It's important to note here that goes on for months at a time, even up to a year, as I previously stated. Over time, the deposited granulation tissue is degraded and excess blood vessels ends up protracting, and this process takes the longest amount of time, as I said. As the wound reorganizes, its tensile strength does increase as well. That presence of the type 1 collagen allows for that. At 7 days, it's believed there's 3%, or studies have shown there's 3% of the final tensile strength in the wound. At 3 weeks, it's about 30% of the final tensile strength. And at 3 months, it's 80% of the final tensile strength. And again, it goes on for about a year. Here, I wanted to find a depiction of kind of the replacement of the type 3 collagen with the type 1 collagen. And so as you can see, as you move on from the proliferative phase to the maturation phase, there is that replacement, and the overall strength of the wound does increase well past the 16 days shown here, but up to a year. So some clinical pearls to take away from this. If a wound has failed to heal within 4 weeks, it's considered to be chronic. Factors that can influence wound healing is age. Like elderly patients typically have a more difficult time. Nutrition, or poor nutrition or malnutrition, poor vascular perfusion. Patients who have diabetes, smoking, peripheral arterial insufficiency, they can have chronic wounds due to poor perfusion, immune suppression, and lower collagen synthesis and poor oxygenation. Medications, as previously discussed, can inhibit and affect the inflammatory phase, as well as radiation and chemotherapy, and also infections can delay the wound healing process. It's very important to balance hemostasis along with allowing the wound to maintain good blood supply while also having appropriate healing. Without further ado, I'd like to present my colleague and next presenter, Dr. Vinny Francio.
Thanks, Dr. Vodapalli. Good evening, everyone. Thank you for joining us tonight. I am Vinny Francio, an interventional pain medicine fellow at the University of Kansas in Kansas City. So for the next section here of the webinar, I will be covering the tenets of Halsted, the commonly used surgical instruments, suture materials, and suture needles. So the basic tenets of Halsted are also known as the Halsted principles. These are a set of basic principles regarding surgical technique and tissue handling. Key principles include gentle tissue handling, maintenance of homeostasis, preservation of blood supply, minimal tension on tissue closures, accurate tissue apposition, obliteration of dead spaces, and crush-free dissection. These were introduced by Dr. William Halsted in the 19th century. He was the co-founder of Johns Hopkins Hospital. He was also a pioneer in founding the first formal surgical training program in the US and developed the principles of sterility, aseptic methods, and surgical closure techniques. Here, I would like to call your attention to the NEC guidelines published in 2022 by Dr. Deere et al. These consensus guidelines discuss the best practice recommendations for surgical techniques for spinal cord stimulation. The major surgical skills that one needs to understand and observe in the practice of spinal cord stimulation or SCS implantation includes both cognitive and motor skills. The key summary is that the NEC guidelines recommends handling surgical tissues gently, identifying appropriate tissues, limiting tissue trauma, maintaining homeostasis, avoiding excessive electrocautery use, and eliminating wound dead spaces, with a recommendation grade B, level of certainty moderate, and level of evidence 1B. Here we have some of the basic materials to create and maintain a sterile field during your surgical case. Hair clippers, sterile towels, sterile drapes, 4x4s, chloroprep, antimicrobial incise drape, light handle covers, and C-arm sterile cover. In particular, regarding hair clippers and hair removal, if you are going to remove hair, it is preferred to use clippers and not razors. However, studies show that there equivalency between hair clipping and leaving the hair, so there's no technical difference there. You can remove it or not. That's surgeon's preference. These two pictures here illustrate an appropriate example of a sterile field, including a square sterile field with appropriate working area on the patient and sterility or aseptic technique of the surrounding environment and the equipment. Here we have a list of basic surgical instruments that are commonly used during these procedures, and we'll go over each one of these in detail within the next few slides. Here we have a picture illustrating a standard Mayo tray for a spinal cord stimulator case. Okay, let's start with scalpels. So these are used for initial incision and cutting of tissues. They are commonly referred by its blade number, for instance, 10, 11, or 15. This can be used for different types of incision with different tissues, keeping in mind the tenets of Halsted to optimize tissue handling. I want to call your attention to the picture on the right, demonstrating a proper fingertip grip, which is the most commonly used. This grip is used to make a long and smooth incision and provides better accuracy, stability, and maximizes the contact of the blade within the tissue. It is critical to exert pressure with the index finger down into the tissue while the skin is stretched laterally by the non-dominant hand, while the blade remains in constant touch with the skin and advances until the incision is complete. Okay, let's cover the electrosurgery unit. This was developed by William Bovey in the 1920s, and it was first employed in neurosurgery cases by Dr. Cushing at Harvard University. The picture on the right displays William Bovey and the first electrosurgery unit models. There are two main functions: dissect or cut tissue and coagulate or seal vessels. And there are two main types: monopolar and bipolar. Monopolar has a stream of electrodes that is delivered directly into the tissue, and then the pad acts as a return electrode. Okay, and then bipolar, there's the electron stream remains between the two tips of the device and is more precise and usually used for tissues with less injury. One surgical pearl when using a monopolar electrosurgery is to use the Adson pickups to optimize seal vessel coagulation. All right, there are two main functions. Like I mentioned, the yellow button is for dissection or cut tissue, separate the tissues and help define tissue planes. And then the blue button is for the coagulate or seal vessels. The electrosurgery unit settings may be adjusted according to the different types of tissues. Commonly used settings include 20 to 40 watts, depending on the type of tissue that one is trying to cauterize. More delicate tissues require less current and vice versa. So for instance, if you're near neural tissues, you want to use 20 watts. If you're near the cervical fascia, potentially 30 watts, and near the lumbar fascia, 40 watts. Always keep in mind the tenets of Halsted and avoid excessive cauterization or incorrect use at the tissue surface, which may lead to increased inflammation, elevated risk of infection, excessive tissue injury, and devitalization or poor wound healing. Keep in mind the phases of wound healing as mentioned by Dr. Vodopalli within the previous section of the webinar. Also, there is no strong evidence that the use of scalpel versus scissors or electric cautery is superior to the other when you are dissecting. The main advantage of using electric cautery is the ability to carry out simultaneously dissection and hemostasis more efficiently. Okay, now let's cover needle drivers or needle holders. There are several types of needle drivers. The decision of which type to use is based on surgeon's preference, the purpose of the use, and also the depth of the tissue. The length of the handle may vary according to the location and the depth of the tissue that one is suturing. A few examples include the Webster type and the Halsey type, which are displayed on the bottom of the slide. These are two relatively short handle needle drivers in comparison to the Mayo-Hager needle driver, which is longer and may be preferred in deeper locations or patients with larger BMI. Next, I want to call your attention to the pictures on the far right of the slide, demonstrating the different types of grip commonly used for needle driving. The recommended use is the one that you are more comfortable with, that you can handle the device with more flexibility, more finesse, and more ease of use. This slide demonstrates the appropriate use of a needle driver or needle holder and a proper needle loading technique. Note that the proper way to hold a needle is by using the tip of the needle driver, holding the 2/3 back at the arch of the needle, as you can see on the third picture on the top. Okay, now let's cover tissue forceps or pickups. There are different types, which may vary based on the size, the design, and the length. The decision on which type of pickups to utilize depends on the amount of tissue trauma, what tissue is being handled, the depth of the tissue, and the surgeon's preference. Pickups are used to manipulate tissues, support tissues while making incisions or suturing. They can be used to retract tissues to optimize the exposure of the field and grasp sutures and needles. In particular, toothless pickups are usually preferred during skin approximation due to the stronger grasp and the avoidance of blood flow disruption and tissue devitalization. Again, keeping in mind those principles of Halsted to optimize tissue healing and manipulate tissues with finesse and in a delicate form. Here I have 3 examples with the ASPN pickups. They are preferred to handle dense tissue or for skin closures. The Debakis, which are used for atraumatic tissue grasping during dissection or for fragile tissues, and then the traditional non-put pickups, which can be used to handle fine tissues and for traction during dissection. On this slide, I would like to call your attention to the proper way to handle and hold pickups with a pencil grip style. Pickups should be held in the non-dominant hand. This grip optimizes tissue handling with minimal trauma, accurate manipulation, flexibility, and the maintenance of a fine and delicate pressure to maintain the tissue characteristics. Always keeping in mind the principles of Halsted. Okay, let's briefly cover a few types of tissue scissors. Scissors are used for cutting tissues, cutting sutures, or for dissection. There are different types based on cutting edges, tips, and shapes. The top one on the slide is the suture scissors. They are used to cut sutures, and remember an importance of the cutting technique. You want to use the tip of the scissors, and you want to angulate your scissors to visualize the knot, so you don't cut the knot. Maya scissors can be straight or curved. Straight scissors can be used as suture scissors, and curved can be used for dense tissue. And then the Metzenbau scissors or mats, they can be used for subcutaneous and superficial fascia, and usually for blunt dissection or for fine tissue. Okay, clamps. There are numerous types of clamps. Here I would like to call your attention to the hemostat, which is the most commonly used type of clamps during our interventions. They're useful to grab tissues. They are non-tooth, so they will want to be traumatic to the tissues. It's important also to pay attention to the Coker type, which is the third one on the screen. They can be used to remove an IPG during revision cases. They are a kind of a tooth clamp that it can be used in particularly of those cases. And finally, you can also use towel clamps or Alice that can be used to secure drapes in place to maintain a sterile field, such as the one in the picture on the bottom of the slide. Next, let's briefly discuss the most commonly used retractors. So there are 2 main types, handheld retractors and then self-retaining retractors. With handheld retractors, the Sen-Mueller type is a smaller type of retractor, easy to manipulate. It can be used to within smaller incisions in comparison to the Army Navy, which is a larger instrument that can go a little bit more deeper and can be using larger incisions. Those are handheld retractors. And then we have the self-retaining retractors via a ratcheting mechanism such as the Whitlander. They can be used to expose the surgical site, and you do not need to hold those in place. You just place it there and they will stay in place. Retractors are used to hold the incision open and maintain a clear surgical field. In terms of suctioning systems, there are 2 main types. They're commonly used in our neuromodulation cases, including the Frazier, which is usually a metal and is preferred for more delicate areas, and the Yankauer, which is can be metal or plastic and can be used for superficial wounds. Suction systems are usually used to remove debris and fluid from the surgical field, and also to clear surgical smoke when you're using electrocautery. Okay, in terms of suture materials, this includes needles, sutures, skin glues, and staples. We will review this in detail within the next few slides. Let's start with needles. So surgical needles come in different shapes, sizes, and materials. The decision on which needle to choose is based on the principles of Halsted with appropriate tissue tension and wound closure, based on the method of suture attachment, shape, and the amount of needle curvature, size, and thickness of the needle and design of the needle tip. 2 main types include the CT or circle taper, which is used to close deep layers, and the SH or small half circle, which is used for superficial layers. So one thing to consider is that the more curved the needle or more acute the angle, it's easier to get a bite of the tissue, such as a 5A circle, which is particularly useful for confined spaces and fascial plane closures. A less curved needle is favorable for subarticular and skin tissues, such as a 3/8 circle needle. And you can see those on the pictures on the right side of your slide. So needles can then be divided in taper and cutting. So the taper, they have no cutting edge, and they are used for repair of very delicate tissues or closure or delicate tissues such as the scarpa fascia. And then cutting needles, they do contain a cutting edge. They can be used for closure of the subcutaneous and skin tissues, to use proper tissue tension with the Houston principles. In particular, the reverse cutting needle is the preferred one for cutaneous suturing, since it reduces the tendency of the needle bending and the suture to tear through the tissue. All right, now in terms of a suture size, so choosing the appropriate suture size and type is very critical. There are numerous sizes available. I call your attention to this picture on the top right of the screen that emphasizes all the different anatomical parts of the box when you get a suture. It is important to understand the different diameters of the sutures and their implications regarding the wound healing, like Dr. Vodopoli mentioned previously. So more zeros indicate a smaller suture diameter, and vice versa. For example, 4.0 or 0.000 is smaller than a 3.0 or 0.00. Sutures should be chosen based on the phases of wound healing, and keep in mind that a too fine suture can lead to wound dehiscence and breakdown, and a suture that is too coarse can lead to wound irritation and a higher risk of infection. Okay, here we have a diagram that illustrates the most commonly used suture options in our field. Regarding suture selection and classification, this can be divided in absorbable, which can be very rapid or slowly absorbable, or non-absorbable. And they can also be divided in braided or non-braided. So braided means that the suture contains several fibers that are twisted and result in a higher tensile strength and are stronger. Non-braided are a single strand of material which lower tensile strength and then therefore less friction. Braided sutures can be used within the dermal layer, so the fibroblasts can attach to the suture and enhance the wound approximation and optimize the tensile strength. So that is the importance of considering the physiology of wound healing and the type of suture that you are utilizing. I want to call your attention on this slide for the NAC recommendations that Vicryl, coated Vicryl, and PDS2 are suitable choices for subcutaneous closure of clean wounds and Ethelon for epidermis closure. There's no clear evidence favoring suture, staples, or skin closure of which one is better than the other. Now I would like to cover in our final slide here on this section of the webinar, some practical pearls in neuromodulation. So to secure devices on the underlying fascia and tissue pocket, you can consider 2.0 Etabond. For fascia closure, you can consider O-Vicryl. For a deep subdermal layer closure of dead spaces, and you can consider 2.0 Vicryl. For a superficial subdermal layer, you can consider 3.0 Vicryl or 3.0 monocryl, which is monofilament. For dermis closure, you can consider a 4.0 monocryl monofilament. For superficial skin and wound closures, then you can consider a 4.0 monocryl monofilament, absorbable, Steri-Strips, skin glue, staples. For infected wound or washout, you can consider a 2.0 Prolene or nylon or staples. You want to choose a suture type that is non-absorbable to minimize the bacterial adhesion to the suture. All right, now for the next section of this webinar, I'm going to introduce Dr. Regan. He will discuss the 3-layer closure surgical technique.
Thank you, Dr. Francio, and thanks to everyone for staying tuned in. I'm Tommy Regan, one of the pain fellows at Rush in Chicago. To finish today's presentation, I'll be speaking on 3-layer closure and wound complications. Source material for this portion, like Dr. Francio's, is largely from the NAC recommendations for surgical technique for spinal cord stimulation, which was published in the Journal of Neuromodulation in January of 2022. So Dr. Francio covered these in the previous section, but here I'd like to just highlight a couple of the tenets, in particular, the preservation of blood supply and the accurate approximation of tissues, as these are crucial for healthy wound closure and complication prevention. So this is a sketch of the subcutaneous tissue layers pertinent to SCS and IPG implantation. When making a subcutaneous pocket for the pulse generator, most implanters use sharp dissection, either with a scalpel or electrocautery, to the desired or required depth. The depth of dissection is usually scarpus fascia in the abdomen, which is contiguous with the thoracolumbar paraspinal fascia posteriorly. The incision depth may vary depending on individual body habitus and battery requirements, but the optimal plane for the pulse generator to reduce the risk of erosion and allow for successful telemetry is approximately 2.5 to 4.5 centimeters in depth when anatomically possible. And that usually corresponds with just deep to the scarpus fascia. So this video shows the tissue layers of the IPG pocket site in a cadaver. The presenter is holding the skin with the forceps in his left hand. Under the skin, you find the first fatty layer. Notice the fatty tissue is globular in nature and the tissue is vascular with the skin blood supply at this level. Under that, you'll see the presenter grab the strong scarpus fascia, which is the side of the first layer of closure. Underneath the scarpas or thoracolumbar fascia is another fatty layer. This layer, you'll notice, is striated, and it's also avascular, which makes it an ideal site to house the IPG. As you can bluntly dissect an avascular plane, and you can also close the fascial layer that's directly superficial. In this next video, the presenter is demonstrating reapproximation of the deep fascial layer. Notice his first pass is deep to superficial, followed by superficial to deep on the opposite side of the wound, which creates a buried knot. He, for the point of teaching, is exaggerating, tugging on his throws in order to show he has the strong fascial layer. As if he had only the fatty tissue, he would just pull the suture right through. So it's only pertinent here to grab the fascia itself. In this video, the presenter is demonstrating the subdermal fascial layer closure, which is the second layer of the 3-layer closure. Notice the pink subdermal fascial tissue, which is contrasted from the yellow fat underneath and the overlying skin. Again, he goes deep to superficial, followed by superficial to deep to ensure a buried knot. Not shown here, but the 3rd layer closure is the skin itself, commonly accomplished by running subcuticular or staples, as Dr. Francio mentioned previously. So layered closure of separate tissue planes is beneficial for several reasons. First, layered closure relieves tissue tension and subsequently decreases the risk of tissue necrosis and wound dehiscence, and thus improves wound healing. Second, the layered closure reduces the dead space between the tissue planes, which helps to minimize hematoma and serome formation, which can serve as a medium for growth of microbial organisms and has been implicated in superficial and deep soft tissue infections. In preparation for closure, adequate hemostasis and copious irrigation should occur. Incisions should be irrigated using normal saline with or without antibiotics, although there is no evidence that antibiotic-containing irrigation is better for the prevention of wound infection. Any debris should be removed before wound closure, and it is imperative to achieve adequate hemostasis before wound closure because excess blood or serous fluid can impede wound healing and serve as a nidus for bacterial growth, like I mentioned. Appropriate wound closure should achieve the following goals: the closure of dead space, support for wound during the healing process, maximization of blood flow, approximation of wound edges, in particular those particular fascias and skin layers that you're trying to close, the minimization of bleeding, the mitigation of infection risk, and decreased bacterial contamination, and provide a durable cosmesis. Wound edges should be everted and well approximated, and closure should provide adequate prolonged support during wound healing. The primary goals of wound care after surgery are to allow for a rapid healing time without infection or complication and to achieve optimal function and appearance. So there's a few key elements to post-operative wound care management. First, the patient's medical conditions and comorbidities should continue to be optimized in the peri-op period to ensure optimal wound healing, including control of potentially modifiable risk factors such as cardiovascular disease, periodontal disease, immunosuppression, tobacco use, and systemic health conditions such as obesity and diabetes. Second, the patient should be seen in your office within 10 to 14 days of surgical intervention to remove non-absorbable sutures or staples based on the degree of wound healing, and to ensure adequate and appropriate education on incisional wound care for the patient and the patient's family, and to evaluate for any signs and symptoms of emerging surgical sites infections. The IPG site is the most commonly infected site in these procedures, and early signs and symptoms of infection may include pain and tenderness, wound erythema, drainage, swelling, dehiscence, and fevers and nausea. If a dressing change or wound cleaning is required in the immediate post-op period, up to 48 hours post-op, aseptic sterile technique is required. But after 48 hours, patients can use regular non-sterile water for cleaning the wound. Should any evidence of early surgical site infection be present, then close follow-up is recommended with regular wound monitoring. So when an infection is suspected, treatment must start immediately. Microbial cultures are crucial to help in appropriate antibiotic selection. When you swab a wound and obtain cultures, it is important to probe the wound deeply in order to obtain a sample from the developing infection and to avoid skin flora or other contaminants. Empiric antibiotics should not be delayed in these patients with signs of developing surgical site infection. And then the therapy should be adjusted based on the results of the cultures and sensitivities. When superficial infection is suspected, i.e. not involving the IPG, the SCS leads, or the neuraxial space, it is acceptable to consider treatment with an oral course of antibiotics and close follow-up. Labs such as white blood cell count, lactic acid, inflammatory markers should be obtained, and you should consider imaging as well if you suspect a deep infection. It's important to get these labs early so that you can follow them for the course if you decide to just watch it and trim them out. So deep infection and abscess typically require incision, drainage, and removal of all the hardware in addition to IV and or oral antibiotics. Complete hardware removal is essential to treat deep infection because partial removal of the device has been linked with higher rates of treatment failure, relapse, and serious morbidity. When complicated SCS infection is recognized, the infectious disease or medical microbiology team should be consulted. In regards to irrigation of deep infection or abscess, some prefer saline, some prefer half-strength betadine or antibiotic-containing solutions. One meta-analysis showed that antibiotic irrigation and betadine irrigation significantly lowered surgical site infections compared with saline irrigation or no irrigation. After you debride and irrigate the infected site, a drain should be utilized to prevent reaccumulation of potentially infectious mediums. Output of the drain should be monitored daily, and drains should be pulled when output is sustained at or below around 20 cc's for a couple of consecutive days. So wound dehiscence occurs when one or more of the layers of the surgical wound separate. This is a rare complication, but this most often occurs between 5 and 8 days after surgery. It's more common in patients prone to poor wound healing, such as patients with diabetes, immunosuppression, connective tissue disorders, and cancer. Wound closure with excessive tension on the wound can lead to ischemia and subsequent separation of tissue layers because of necrosis, but failure to sufficiently tighten and close the wound may also lead to dehiscence. So there's a medium there to find. Techniques for the management of wound dehiscence in the setting of neuromodulation procedures is largely anecdotal. If there is no evidence of infection based on the patient's symptoms and labs that you've drawn, et cetera, salvage of the system may be attempted with wound debridement and closure with sutures or a vacuum-assisted closure system with or without antibiotic coverage. But if there is evidence of deep infection or if salvage of the system fails, the neuromodulation device must be removed as we had previously discussed. So that concludes my portion on wound closure and complications. I'll swing it back over to Dr. Lubenow now.
Well, thank you everybody for that excellent presentation. We have a couple of questions that have come in from the audience. And there's one specifically addressed Dr. James first. So let me please ask Dr. James. Dr. Moreira asks, are there any specific considerations for infection prevention for paddle lead placement versus the percutaneous cylindrical lead placement? Is there any evidence one way or the other? And do you ever consider that in your technical placement of electrode positioning?
Thank you so much for that question. And when I do both paddle and percutaneous lead cases, I use the same aseptic sterile technique and draping for both cases. And I am not aware of any data that shows any significant difference between infection rates with paddle versus percutaneous lead placements. When I am doing the paddle lead placements or removals, I am considering that I'm going 2 layers deeper in the spinal area versus just a percutaneous lead placement. So whereas you anchor the percutaneous leads to the paraspinous fascia, in the paddle surgeries, you are actually incising that paraspinous fascia and then dissecting the paraspinous musculature off of the spinous processes, and then doing a small laminotomy in the lamina of the vertebral level that you're working. So that is going to add additional time to the surgery. We do know that additional time increases risks for infection. So with all cases, both paddle and percutaneous lead placements, you want to eventually speed up your time in a safe way so that you're getting that patient on and off the table as quickly but safely as possible. That will minimize your risk. I do extra irrigation in those paddle lead placements more than I do for the percutaneous lead placements. And again, I think that's probably surgeon dependent and specific. So just you're going through 2 additional layers with those paddle leads. So 2 additional layers that could potentially get infected. And I will actually ask a question to Dr. Vodapalli. Dr. Vodapalli, what are some considerations you might want to discuss with your patients in the preoperative visit, especially those patients with multiple comorbidities, specifically diabetes? What touch points do you want to make sure you discuss with those patients in terms of their risks with wound healing?
Yeah, absolutely. Thank you for the question, Dr. James. So those patients who have poorly controlled blood sugars, again, like I mentioned in one of the slides, it can affect the vascular supply because it is a microvascular disease that can affect smaller blood vessels, which can affect the wound healing process, and as well as the different phases, possibly specifically the inflammatory phase. So it's important to discuss that with your patients before you end up doing any of these surgeries, and discussing proper glucose management before and especially afterwards too, because that might end up prolonging the wound healing process for you, which I mean is never good, can lead to infection, etc. And along those lines too, I think it's important to make sure looking at guidelines for stopping anticoagulation therapy before the procedures. The NAC guidelines is a great place to start and look at that and understand how different agents have different durations of actions or longevity in our system. So knowing when to stop them is important. So
thank you. And for Dr. Regan, in addition to the traditional inverted mattress stitch with wound closure, is there any other additional stitch you might consider, especially for patients whose wounds are taut, or perhaps post-infection you remove an IPG and there's actually necrotic tissue that you have to remove at the wound edges? How might you think about closing that particular wound, and what stitches might you consider?
Yes, ma'am. In that case, I think you should probably consider a vertical mattress suture. It allows you to get a little bit more of a tissue bite on each side of the incision. In the case of a taut incision, you could, hopefully get those wound edges closer together than just having that one small bite on each side.
Excellent, thank you.
And Dr. Francio, let me ask you, when you consider suture material and you're planning to suture anchors around electrodes, what are the different materials that we have at our disposal, and what do you reach for first? Is there any difference between, let's say, silk or Ethibond?
Yeah, so we have several options available, and obviously the most important piece of advice is that for the fellows that are on the panel, is to read the NAC guidelines. I think for me, when I was preparing this presentation, that was very helpful. So that's the first thing I recommend. You obviously, when you're anchoring leads and IPG devices, Ethibond is the most commonly used suture material that we use in our practice here. It is a non-absorbable material and is braided. So that means that you have several fibers twisted, is a stronger. It maintains a better tissue, or has a more tissue drag, has a higher tensile strength. It is easier to handle, and it's also easier to tie a knot. So all those reasons, that is usually the type of suture that we use here in our practice most often, to secure anchor and leads, secure anchoring leads and IPG devices to the pocket. So that's what we usually use.
And then let me throw out, there's one other question that comes from the audience here, and this is for anybody who wishes to answer. Since we've had an evolution in dressing care, can anybody comment on when one would decide to use some of these negative pressure wound vac type dressings that have come into more common practice, as opposed to just say using a typical closed suction drainage like a JP type drain?
In my practice, I would consider using the negative suction wound closure options in patients with a history of poor wound closure, a history of postoperative wound infection, and who are just at higher risk at baseline.
Yeah, I think from my perspective, one of the goals with managing postoperative wound infection is be there to identify the wound infection early on. And if you do that in a prudent fashion, it's usually sufficient to close the wound and use Jackson Pratt or some other type of small closed suction drainage equipment, and you don't have to necessarily go on to that larger type of negative pressure wound. So that's really the key, is to have follow-up. And if you have patients who have a suspicious wound, follow that longitudinally with some of the laboratory values that were talked about earlier in our presentation. And as soon as you see 2 or more of those increasing, white count with sed-rate, white count with C-reactive protein, or just more and more tenderness, then you take them back to the operating room. And it's much better to do this at an earlier point in time than waiting too late. With that, I would like to thank everybody for their kind attention tonight. As I said, this has been an Aspen Fellows webinar where fellows are teaching other fellows. And I want to bring to everyone's announcement some of our next upcoming presentations. Later on this month, there'll be a Aspen presentation, a webinar that's designed to go over new technology to improve the informed consent process. That's going to be for our general membership at large. And then one additional webinar is going to be a month from now. This is another one of our fellows webinar in this series of fellows webinar. This is going to be November 14th, and it's entitled Lumbar MRI, Understanding the Basics to Facilitate Interpretation. And it's really meant to be a springboard to highlight and review the MRI findings that we see in the more common conditions that we treat: lumbar stenosis, disc pathology, and the like, in terms of how do we plan then the next step of treatment after we understand what the MRI anatomy is. And so with that, I'd like to thank Dr. James for volunteering to serve as my co-moderator tonight. I'd like to give kudos to all of our presenters, our panelists, who did a terrific job in preparing for tonight. And I want to wish everybody good night for everybody who signed in and listened. So thank you for your kind attention.